I want to talk to you today about directly observed treatment for tuberculosis. It's a controversial topic. DOT, as it's called, means treatment observation by someone who is accessible to the patient and accountable to the health system. That does not include family members in general. It's one of 5 components of the DOTS strategy, the original DOTS strategy that was clear and a mechanism for rapidly controlling tuberculosis. The other 4 characteristics were political commitment, good quality diagnosis, good quality medications, and rigorous monitoring. The hardest of the 5 is actually the rigorous monitoring, and I'll discuss that another time. But I want to talk about directly observed treatment because there was a big backlash against it. The idea was that it was paternalistic, unnecessary, unscientific, and just a way of people trying to control tuberculosis patients. This was really puzzling to many of us who have treated lots of people with tuberculosis. First, non-adherence is very, very common. About 1/3 of all patients don't take medications as prescribed. If you're taking medicines for something that's for yourself and you have a bad side effect or a bad effect, if you don't take those medications, that's your problem. But in tuberculosis, it's different. Your right not to take your medicines ends if you develop a drug-resistant bacteria that you infect somebody else with. And what's more, there's no way we can predict which 1/3 of patients are going to be less adherent. It's not correlated with educational levels. Doctors are some of the worst patients. The second issue is that the risk is really quite substantial. If someone doesn't take their tuberculosis medications, they can become much more infectious and can develop drug resistance. And the reality that puzzled us so much is that anyone who's done directly observed therapy, anyone who's run a program for DOT, knows that it's about providing services to patients. It's about developing a human bond, so you help the patient come back into society. Now, the error of this really drove me crazy because a bunch of academics who had no idea how to run a tuberculosis program studied what they actually called in their studies supervised swallowing. Well, guess what they found? Surprise, surprise. When you do directly observed treatment as supervised swallowing, you provide no extra services. You don't build a human bond. It doesn't help. In fact, it does no better than lousy treatment that's unobserved. But it does much worse than good directly observed therapy. The reality is that when DOT is done well, it's about building a relationship. It's about supporting the patient. It's about addressing their other social and medical needs. It's about helping them become a member of society again. It's overcoming the stigma that they face, the barriers that they face, so they can get past their tuberculosis and have a healthier future. As we move forward, we need to do much better with tuberculosis control. Better diagnosis, better treatment, better monitoring, and better support for patients, including through DOT, whether it's video DOT or some other form of convenient support for patients.